A very good evening to all. I'm Dr. Vishnu Mohan, Secretary of NNF Kerala and Organizing Secretary of IEP Neocon 2021. I have great pleasure in welcoming you all to the 17th webinar of Learn from the Legends. We have with us today one of the legendary legends in neonatology, Dr. Michael NARVEY is a Medical Director, Child Health Transport Team, Health Sciences Center, Winnipeg, Manitoba, Canada. He'll be speaking to us on what dogmas in neonatology are in need of change. Welcome, sir, to our program. I also welcome our moderators for the day, Dr. Sanjay Wazir from Gurgaon and Dr. Arjit Mohapatra from Bhubaneswar. Welcome, sirs. A hearty welcome to all our dear delegates. I request our moderators to kindly take over for further proceedings.
Thank you, Vishnu, and thank you, Michael, for being here. And since you are from Canada, so I thought I'll take a quote from William Osler, who was one of the Canadian physician and one of the founders for Johns Hopkins University. And he said, medicine is a science of uncertainty and an art of probability. And he also said, the greater the ignorance, the greater is the dogmatism associated with it. And that is why probably so many dogmas are associated with this science of uncertainty. Absence of evidence is not evidence of absence. And the fact that you have not heard or known something is not a proof that it does not exist. In neonatology, we have come across, in last century, we were giving oxygen, thinking that oxygen is required for all children at birth, for them to breathing, only to realize in last 20 years that it is probably increasing mortality. And there are umpteen examples of such dogmas, from gestation-related DP, babies not experiencing pain, awake, intubation. There's so many dogmas, and to dwell on this, we have a renowned speaker, and I would expect Dr. Arijit to unravel the physician, the neonatologist, and the expert to the august audience. You're not audible, Arijit. Arijit, you're not audible.
Okay, sorry. So thank you, Sanjay. I give a warm welcome to Dr. Michael NARVEY, the guest of honor for the topic today from Learning from the Legends. Dr. Michael NARVEY is the section head of Neonatology, Medical Director of Child Health Transport Team, Health Science Center of Winnipeg, Manitoba. So I have the pleasure of introducing Dr. Michael NARVEY today. He began his training in pediatrics at the years of further training in neonatology for University of Manitoba at Winnipeg, where he completed his training in neonatology, which is followed by 2 years of neonatal fellowship at the University of Alberta in Edmonton. Afterwards, he began his career in neonatology in the same city over the 6 years he spent there. During his career includes both clinical and administrative duties, including 4 years as the fellowship program director and 2 years as the medical director for a level 2 unit. In late 2010, he accepted a position in Winnipeg to become the section head of neonatology and continues to hold this post as on date. In 2016, he took on the additional role of medical director of the Child Health Transport Team. In 2015, he became a member of the Canadian Pediatric Society's Fetus and Newborn Committee, and in 2019, he took chair of the same committee. His interests are predominantly lie in the use of non-invasive technology to minimize the painful procedures during an infant stay in Nicu, and he is very active in social media, in Facebook, blogs, and other things, and has a passion for fundraising, and is an active board member of the Children's Foundation of Manitoba. I give again a warm welcome to Dr. Michael NARVEY, and thanks to Dr. Vishnu Mohan, Dr. VC Manoj, and team of NNF Kerala, IIP Kerala, and NNF India, and IIP Neonatal Chapter. So I welcome Dr. Michael NARVEY to start his session for the day. Thank you.
Thank you for such a warm welcome. I'm going to start my slide share, and as I do that, I'd just like to acknowledge it's quite the honor at this point in my career to be considered amongst the legends of neonatology, but I'll take it. I'll take it as a very nice gesture. So thank you. So this talk really, you mentioned the background in social media, and we'll get to that in a second, but the origin of this talk, I believe, came from social media. For those of you who, whether you're on Twitter or Facebook or LinkedIn or whatever platform you like to use, you're always needing to come up with new content, for education, to keep people interested. And one of the things that I realized one day was, as I've gotten on to what I would consider my mid-career, I started to think about all the things that we do on a daily basis in the NICU, and really what's the evidence behind doing these things, and how difficult it is to change some of these things. And so I posted on Twitter or Facebook a YouTube video in which I asked people about dogmas in neonatology that were in need of change. And so in the introduction, you heard about a number of things that one could consider in potentially in need of change, or at least a question. And I've chosen 4 today to discuss with you. But certainly this could be a series unto its own, challenging what we do, on a daily basis. So speaking of social media, if you're looking for some of this content, because I certainly have talked about some of these dogmas or challenging some of the dogmas, you can find me at these different sites. And I know at least one of the organizers here follows the blog. So hopefully the content is of interest to you guys. So I have no conflicts of interest to disclose. And we're going to start with dogma. So just so that we get the definition over and done with, so to speak, so we're all on the same page. This is from the Merriam-Webster Online Dictionary. And what I wanted to draw your attention to clearly is the two sections that are in highlight. But a definition of a dogma is something held as an established opinion, and C as a point of view or tenet put forth as authoritative, without adequate grounds. And so when you look at the two words, opinion without adequate grounds, I think that's what we're often talking about when we think about dogmas in neonatology, or dogmas in medicine, period. Things that may, and I'll add the word may there. So it may be an opinion without adequate grounds. And in the end, when you think about it, when people say the evidence says this or that, really what they're saying is, in my opinion, after evaluating the evidence, this is what I believe to be true. And so we're going to look at 4 things today, and we're going to see whether or not they stand up, and at least I hope today to raise some questions in everybody's mind. So the first thing is a couple slides just to put everyone's mind at ease. I want to remind people to keep calm and remember it's not your fault. Okay, if you believe in these dogmas, and just so we're clear, there are dogmas that I have believed in fully and not even questioned for many years. And what are the reasons why we hold them so dear? Well, the first one is going to be, it's what our mentors taught us. We have the blessing in neonatology of having worked with some incredible, we talk about legends of neonatology. We've worked with legends of neonatology who taught us, as part of our fellowship programs or pediatric programs, how things should be done. So that's one reason. And we have great respect for these people. And the question is, how could they be wrong? The second point is, and this is a common expression, if it's not broken, don't fix it. If what you're doing seems to work, you would be inclined not to change it. Third thing that we tend to hide behind is we tend to hide behind unit policy or guidelines. So if we are comfortable doing something, we may defend continuing to do it because we say it's the unit policy. The fourth one is a bit of mental trickery. As we get, the expression "you can't teach an old dog new tricks" applies here, because as we begin to develop into an advanced clinician, we get very accustomed to doing things the way we've done them. And to change to have a paradigm shift in the way we consider an approach to something takes a lot of mental energy, and we may or may not be open to that. And then the fifth point is you don't know what you don't know. And I don't have the data, to share with you, except I could say the amount of literature that comes out on a weekly basis, now that there are so many journals that have neonatal content, it is a really, really tough thing to keep up. So when people say they've not heard of such and such a study, I never fault them for it. Because the reality is what I might find, and you might find this today, I might share with you studies today that you've just never heard of. It's not your fault, it's just you haven't come across these studies. So at best, what I'm hoping to do today is create some thought, create some things for you to think about. And back in your own units, you can decide whether or not this makes sense to you or it doesn't. So the ground rules. The first thing is you are going to be challenged, potentially, you're going to be challenged in what you think in terms of your own practices. But I'm going to let you know you will be okay. So there's nothing that should come today that will cause you emotional or mental trauma. I'd like you to keep an open mind. You may be shocked by some of these things that practices we've long done, and looking at what the evidence is to the contrary. And the third thing is, I don't expect anyone to change anything after this talk. My goal is not to convince you that you must change your practice, but it is, the goal today is really to get you thinking about some of the things that maybe have been traditionally done. And then the fourth point is, don't worry, your mentor is safe. If you have great respect for your mentor, you should, and you may continue to do so, because I believe we all try to teach, and we all try to share what we believe is to the best of our knowledge. Whoops, frozen slide. There we go. Okay, so the dogmas. So here are the 4 topics, and again, just in the interest of time, there's only so much I can talk about. So each of these I will be touching on an important paper or papers that make a case for maybe challenging the dogma. But certainly there's probably 100 of these that we could have talked about. So as I said, not that I'm trying to create my own series, but I'm sure we could over time challenge a lot of dogmas together. So the first one is cycled versus continuous phototherapy. The second one is the use of heparin in peripheral arterial lines as flushes. The third one is when we need to place a UVC for higher dextrose concentrations. And the last one is something that really fits in well with my bio. When you heard that I have a strong interest in non-invasive technology and minimizing blood work, this sort of the fourth one fits in with that. And so I'll expand a little more on that one than the others. Okay, so dogma number 1. Patients receiving phototherapy should remain under phototherapy at all times. The reason I wanted to touch on this is because some time ago, it was probably a couple years ago, there was a mother that wished to breastfeed, and the baby was put under intensive phototherapy. And as per our unit guideline, babies who are on intensive phototherapy were supposed to be kept under phototherapy at all times. This began to raise in my mind a question of whether we were doing the right thing. What was the evidence for keeping babies under phototherapy at all times? And so just a bit of background here. I think everyone here knows, and I wasn't sure if everyone knows, based on the audience, that bilirubin is converted to lumorubin, which is then excretable, and that's how phototherapy works. The assumption, and there's some assumptions that we make when we're using phototherapy. Number 1 is that the greater the surface area exposed to light, the greater the reduction in bilirubin. The other thing that we would assume, I think many people would assume, is the longer the duration of phototherapy, so the longer the contact of the light source with the skin, the better the reduction. And the more light sources you have. So people, we used to have single phototherapy, double phototherapy, triple phototherapy. The more light sources you had, the greater the effect. And as per the Canadian Pediatric Society, we try to see a reduction of about 35 micromoles per liter per hour under intensive phototherapy. I have to say I've seldom seen a drop that fast, but certainly if you ask most clinicians, how would you go about reducing bilirubin the fastest, they would cite some of these things. But then, as I mentioned, what do you say in your units when you're trying to promote breastfeeding, and at the same time you've got a belief that taking the baby out from the phototherapy lights is harmful? So you're forcing people to seemingly choose between promoting breastfeeding and safety, being outside of phototherapy. And the question is, do you really have to choose? There actually isn't a lot of literature on this. Back in April, so this is a very recent paper, this was within the last year, this paper caught my eye, and I wrote a blog post about it. And the reason it caught my eye was because it followed up on a paper, I believe from the early 2000s, or it might have been in the 90s, in which British researchers found that infants under 750 grams that were exposed to intensive phototherapy had increased rates of mortality. To my knowledge, that was the only paper that I've seen that indicated that sort of risk. And so these authors, what they chose to do is they chose to look at infants who were between 400 and 1,000 grams. So I will state up front, this is not looking at term infants, so we'll have to be careful in extrapolating. But what they did look at was, this was what they called a dose finding study. And so what they did was they compared continuous phototherapy with 30-minute intervals of phototherapy and 15-minute intervals of phototherapy. After 305 infants, what they identified was when they looked at peak bilirubins, time under phototherapy, there was no difference in the groups that were in the 30-minute or the 15 minutes. So they stopped the 30-minute group and ultimately carried on with just continuous phototherapy versus 15 minutes every hour. And what I really liked about this study was they had, because this was prospective, they had already pre-planned if babies reach certain levels of bilirubin in the serum, at what point they would change to continuous phototherapy. So this was planned. Spectral Irradiance, which as you all know is a measure of intensity of phototherapy, was standardized, as was the timing of testing, and the light sources were all the same. So you had the same degree of phototherapy. The only difference in this study was the duration of phototherapy. And what they found, I found fascinating, and is the reason I brought this to you today. When you look at their table 3, you can see in the main outcomes, they had, when they looked at all patients, there were 128 in each group. And they found that the mean peak bilirubin was not significantly different, whether you were under 15 minutes or whether you were continuous. And when they looked at high-risk patients, so patients who had significant risk factors for hyperbilirubinemia, there was absolutely no difference in the peak bilirubins. What they did find, though, was when you look at towards the bottom of table 3, when you look at the phototherapy duration, obviously, when you're only under 15 minutes instead of under under continuous, the duration is going to be a lot different. And that's what they found, is strikingly lower number of hours of phototherapy as means when you were under the phototherapy for 15-minute intervals. Interestingly, and of course the study was not powered to determine this, but the mortality rates were no different between groups. And then on the right, you can see the figure 2, which was looking at the phototherapy hours per day. And you could see in the first week, there were differences between the amount of phototherapy given. per day, and that's not surprising. And so the bottom line is you could get away with a lot less phototherapy without changing the peak bilirubin. Additional benefits, this is from a study back in 2015 by Rami, and there's been other studies that have looked at this concept of DNA damage with phototherapy. And the study by Rami, this is one of the figures, and what it looked at was rates of DNA methylation when you're on either intensive phototherapy or conventional phototherapy. And then it also looked at duration of phototherapy. And the bottom two bar graphs in this slide show, the one on the left is measuring duration. So the longer the exposure to phototherapy, the greater the DNA methylation, which is a marker of DNA damage. Interestingly, when you look at conventional versus intensive phototherapy, there is no difference in rates of DNA methylation. So what this study demonstrated was that when it comes to a proxy for DNA damage, and then we worry about future cancer risk, the duration of the phototherapy is important, but not the intensity. And so that certainly raises a question when you're also coupling that with finding that there's no significant difference in the use of intermittent phototherapy versus continuous phototherapy. So recommendations. So, and again, this is just like dogmas start off with an opinion. My opinion is that cessation of phototherapy for breastfeeding, based on this study, seems unlikely to cause harm. Could we, as a side effect of this or a side benefit, get improved breastfeeding rates by not interrupting breastfeeding? Also, we just talked about the risk of potential implications for long-term risk of cancer. I'd like to put forward that we don't have any evidence that phototherapy does put infants at risk of cancer, except what we don't know is that effect of increased DNA methylation. I don't think anyone's looked at that long-term outside of cancer. As I stated up front, this was done in babies that were quite small, between 400 to 1,000 grams. Would you see the same effect in larger babies? That obviously needs to get tested. Having said that, I think that on a case-by-case basis, one could certainly look at taking breaks for short periods of 20 minutes and without any evidence that that truly would be detrimental. Of interest, on clinicaltrials.gov, this group is looking at a much bigger cohort now of 1,700 babies that they're planning on completing by 2024, because again, this initial study was dose finding. So looking forward to seeing those results. So dogma number 2, using heparin flushes for maintaining peripheral arterial catheter patency. I don't know how many people or how many centers that are watching have traditionally flushed their arterial lines with heparin, although we certainly did. So, excuse me. So why might you want to flush your heparin, or why might you want to use heparin in your arterial lines? The most common belief will be that if you use saline flushes, that may lead to increased rates of occlusion. There could be more catheter failure. People have cited the risk of thrombophlebitis that's reduced with heparin. And then the last one is probably the greatest reason, which is getting a peripheral arterial line into especially our tiny babies, we all know can be a significant challenge. And so these lines are deemed precious. Dr. Manoj Kumar published a systematic review, and actually some of you may know Manoj. He was a colleague of mine in my days in Edmonton, and so he published this in 2013 after I had left Edmonton. And to me, this is probably the best evidence that we have out there, and it's there's very little since this systematic review was done. And so he looked at all literature that had been published on the use of heparin as either flushing or continuous infusions. And as you go through the screening diagram here, you see at the end, he gets down to the point where the majority of RCTs have looked at use of heparin flush. That was 10, and a minority had actually looked at continuous infusion. When you look at the forest plots for catheter patency. So these are, the duration. This is duration of catheter patency. What you see is in the 3 studies done on infusion, continuous infusion, heparin seems to make a difference. Heparin prolongs the longevity of a catheter, peripheral arterial catheter, by about a day, 26 hours. When you look at intermittent flushes, though, the confidence interval just crosses 0, sorry, with a difference of just under 3 hours. So there's not much of a difference seen when you get to intermittent flushes in terms of hours of use that you'll get out of a catheter. And then when you look at infusion failures, so simply the likelihood that the catheter will last as long as you need it versus fail, you can see that for intermittent flushes, heparin does not make a difference again. And so the reason I shared this with you is because just wanted to show you that it's we practice what we preach, or at least we try to practice what we preach. And in Canada, something interesting happened back in June of 2020. We had been flushing for many years our peripheral arterial lines with prepackaged half normal saline with heparin. The manufacturer stopped producing this, and our pharmacy asked us to look into the evidence behind the use of flushes with heparin. And ultimately in July, we sent out this, we have a newsletter that comes out every month. And what we said, and there's actually an error in the newsletter. I have to confess, I didn't write the newsletter, but certainly endorsed it. So it said, we are using up our stock heparinized normal saline flushes. When it is gone, we will be using only normal saline to flush the lines. I surveyed across Canada, and the majority of places have, that should actually say, have not been using heparin, not have been using heparin. And we switched from half normal saline to normal saline back in December with no adverse effects. And so as of July 2020, we stopped using heparinized saline. So this was a dogma that we had in place for many, many years. And to be frank, I don't know if this was something that many people even gave thought to because it had been in place for so long. But that just shows you that that's something that we changed. And I would question, does your center use heparin? And based on what I've shown you, should you? So dogma number 3, a UVC needs to be inserted for any infusion greater than D15W. If I think back to when I was a medical student or pediatric resident, this was probably one of the first things I learned about neonatology. If you had a baby who had hypoglycemia, you would begin with using D10, and then you'd go to D12.5, then you would go to D14, and then once you got to D15, it was a mandatory insertion of a UVC. That was what I was taught. And then this dogma actually goes back quite some time. Many years ago, I was caught in a bit of a pickle in a baby that we could not get a UVC into. The baby needed D15 or maybe needed D17 and a half. And I went to the literature to see what I could find to demonstrate the evidence for actually needing a UVC to run these higher concentrations. And I found this study. This was published back in 2010, and to my knowledge, I think this is really one of the only studies out there. This was a study out of Finland, and it really was answering the question that I was really setting out or it was addressing the question that I was trying to set out to answer, which was, are glucose infusions into peripheral veins in the management of neonatal hypoglycemia is 20% different than 15%. So what they looked at was these were all older infants. So these babies were all over 2 kilograms. And what they did was they randomized to either getting 15% or 20%. And what they did was these were all infants with hypoglycemia. They provided 8 milligrams per kilogram per minute. And so you can imagine then with the different concentrations, the IV rate was different. But essentially what they did was by standardizing the amount of dextrose that was going in at 8 milligrams per kilogram per minute, they simply looked at whether the concentration of that dextrose infusion made a difference to such things as catheter longevity and phlebitis. And they based their power calculation on reductions in cannula site changes. So they were looking to see how many times they would lose the IV as a way to calculate the number needed. Ultimately, they also used something that I have to admit I was unfamiliar with, which was the modified Maddox score scale, which is a validated scale for measurement of phlebitis. And so at every time there was a catheter site change, they applied the Maddox scale and to try to be objective about the degree of phlebitis. And so you can see in the end, they had roughly the same amount of patients. I think they needed, if I recall, 57 per group. They wound up with 60 in the 20% group and 61 in the 15% group. And what was good for me at the time was that the outcomes were no different. So the mean duration of cannulation was in the D20 group was 4.2 days the IVs lasted versus 3.9 days in the D15. Now, there isn't a group here because in fairness, you could say, well, Dr. NARVEY, you're making a case for no difference between D15 and D20. What if they had just run D10? How long would the IVs last? I would put to you, and I hesitate to use the expression in my experience, as I was told once, one should never say that until you've been in practice for 30 or 40 years. But what I could say is, if we're being honest, I don't know of many peripheral IVs that make it much past 4 days on average. Our IVs do tend to get changed over. So I don't think that these numbers are really out of keeping with what we would see for other IVs. The number of cannulation site changes had a median of 1 in the D20 group and 1 in the D15 group. Using that objective measurement of phlebitis, there was no difference in rates of phlebitis. Rates of phlebitis were in the D20 59% versus 60% in the normal saline group. So ultimately, what it appears here is that whether you use D15 or whether you use D20, it doesn't really make a difference in loss of IVs, phlebitis, or need to change over your IV sites. I have to admit, I took an extreme example here, but I wanted to acknowledge that some people would say, well, what's the big deal? We're comfortable putting in UVCs. This was a single center experience from 2016, and I imagine many of you would say, well, you wouldn't have these results, but they found 95% of the time the catheter was not in the perfect position. It was either low or it was high. I don't think our numbers would necessarily, I don't think our numbers would be 95, but I can say anecdotally that I do see a lot of catheters that after initial insertion have to be manipulated. When you look at other things like going into the hepatic vein, that was quite common. And of course, catheter-related bloodstream infection, thrombosis, these are other concerns that can happen with a catheter. Now in our own center, as I mentioned, I try to practice what we preach. Change is hard. And I said that at the beginning, if it's not broken, don't fix it. Paradigm shifts in getting your brain to shift the way you think about approaches to things are challenging. So several years ago, it was actually many years ago, based on this study, and based on the idea that why should we use an umbilical venous catheter when we don't need to, I had sent out a memo to confirm that one could use D20 in peripheral arterial lines, up to D20 in peripheral venous lines. However, as I mentioned, change is hard. And many mornings I've come in to find a UVC placed for babies with hypoglycemia. And when I asked what the indication was, I'm still told it was because the baby needed D15 or D17. Now, I would conclude this by saying, I'm not telling you you can't use or you shouldn't use a UVC, but I am saying that based on the evidence that is out there, there really doesn't appear to be a compelling reason to put in an umbilical venous catheter for dextrose infusions up to D20. Okay, so we're going to move into our final dogma, which is routine blood work is necessary to avoid missing important aberrations. I don't care which unit you work in, chances are you have some blood work that you have standardized. And the reason for standardizing the blood work, it could be, for example, TPN. Maybe babies that you start on TPN, you choose to have a standard approach so that you avoid any hypocalcemia, hyperphosphatemia, or other metabolic derangements. Another reason might be, for example, in babies with hypoxic ischemic encephalopathy, our own unit has blood work which is drawn every 6 hours. And again, you're looking for aberrations and not wanting to miss it. Why do we love routine blood work? And I would argue we really do love routine blood work. One of the reasons that you'll hear cited is we're always worried that we're going to miss something important. Another reason we love routine blood work, when units are busy, it's easy to miss something. And you'll hear this quite often is that, when units get really busy, it's hard to devote the attention that's required to some of the babies that are less acute, and things may get missed. I would also flip that over. I haven't included it, but I would flip it over and say, sometimes when units are really quiet, it's easy to miss things as your brain downshifts and you're not thinking as acutely as you were before. I can't speak to the situation in India, and certainly Canada, we don't see a lot of litigation, but certainly if there are any people who are practicing out of the United States, one of the other reasons for routine blood work is a fear of litigation, that if you miss something, you would put yourself at risk of being sued. And interestingly, at one point we had in our own center, we had someone who had worked in the United States who moved to Winnipeg and started practice in Winnipeg. It was quite shocking, the amount of blood work that individual ordered in comparison to my other colleagues, myself and my other colleagues. So that certainly is, and when I asked about it, what was cited was exactly that, was that in the US, there was a significant fear that something could be missed. Now, if you do routine blood work, or if you do blood work, the more blood work you do, there are consequences to that. And so this was a systematic review from 2016 by Cruz and others out of Portugal. And the information gleaned from this paper I found to be somewhat disturbing. And so they looked at 18 studies, and these were 282 stable. And I've capitalized stable preterm infants there because, of course, you would see or expect to see in sick babies justifiably, if a baby's quite sick and on a ventilator and they're unstable, they'll need frequent gases and so forth. But these were stable infants, and they examined the frequency of painful procedures in the NICU. In the first 2 weeks of life, the average number of painful procedures, which would include things like phlebotomy, could be art lines, could be heel sticks, was 7.5 to 17.3 per day. And when you looked at the total stay, the average for the total stay was 17 pokes per infant. So these would include babies that, and again, these are stable infants. So babies who shouldn't, necessarily need a lot of investigation because they're stable, still wound up with an average of 17 per infant. When you look at when you focus in though on preterm infants, extreme preterm infants, this was a study looking at babies under 28 weeks of age. And what they found was out of 20 infants,
that were studied, they found a number of things. So one of the things, so if you base, if you look at the average infant and conclude that they have about 85 or 90 mils per kilo of blood volume, what they found under 28 weeks was that the total cumulative iatrogenic blood loss was about 25% of their blood volume. When you looked at the total loss in the first 28 days in mils per kilo, it was 24.2 as an average. The volume of RBC transfusions per neonate, 30 per kilo, is actually just over the amount of iatrogenic blood loss. The number of punctures was in under 28 weeks. This is in the first 28 days, was 47, and the interquartile, these are interquartile ranges. The upper boundary was 56, but the range was up to 116. When you look at the bottom in the second figure, what you can see, and this shouldn't surprise you really, is that when you look in mils per kilo at iatrogenic blood loss on individual days, the bulk of the blood draws, or the greatest number of blood draws, occur in the first 2 weeks of life. And that's not really that surprising, as the babies are getting investigated and in their most acute stages at that point. When you look under 28 weeks at individual gestational ages, you can see that, not surprisingly, the smaller the infant, the greater the cumulative blood loss. However, the smaller the infant, the less they can probably afford to lose that blood. So that's something certainly to consider. So the question then is, if we can all acknowledge that we do a lot of poking, we do a lot of blood work in preterm infants. If you were going to try to reduce the amount of blood work, if you were going to try to get rid of routine blood work and do targeted blood work, how could one go about this? What would work? So this is an adult study, and this is, I believe, also from 2020. And they provide some interesting statistics, and I think you could probably extrapolate these to the neonate. So about up to 5% of healthcare costs are actually related to laboratory testing. Staggeringly, about a quarter of all testing in research studies has been found to be done inappropriately. Excessive testing is not benign. As demonstrated in the study of babies under 28 weeks, iatrogenic blood loss, which can be up to 25 or 30% of an extremely preterm infant's blood volume, can lead to anemia. And then furthermore, as we all know, the more tests you do, the greater the likelihood that you're actually going to find an abnormality, which could be just a variant of normal for that infant, but that will lead to further investigations and can prolong stay. And at least in Canada, one of the most significant drivers of financial cost is the length of stay. Back in October 2017, the Choosing Wisely campaign came out with this, which was endorsed by the Canadian Society of Internal Medicine, the Canadian Association of Pathologists and Resident Doctors of Canada. And it was for those of you who don't know, Choosing Wisely is an international campaign looking at coming up with recommendations for best practice, things that we should always be trying to do. And the concept here was, the slogan was "Pause the Draws." And they provided a toolkit for reducing repetitive routine blood draws in hospitals. Their recommendation was, do not order repeat laboratory investigations, particularly the CBC and chemistry, when patients demonstrate clinical and laboratory stability. When you think about your own units, ask yourself how many times in passing, as you're walking past a bedside and a nurse says, when would you like the next blood work? What that does is, by asking when would you like the next blood work, the presumption is this child needs blood work. How many times do you say, why don't we do lights in the morning? Why don't we do a CBC in a week? We need to think critically about who needs what and try to stop being reflexive. I love this figure, because this figure
was from the reference below. It was an ISMP medication safety alert. And I think we should all think about this. And basically what it does is it's a hierarchy of strategies that one can use to that you could apply here for reducing blood work. And they begin on the bottom three with person-oriented. And I'll just give you some examples. So training and education is what we often think about doing. So let's say you want to do a change in your unit. You may or may not have an education, a nurse responsible for education or a team responsible for education. You send out a notice, you go around to the bedside, you teach people, please stop doing this, please do this instead. And you say, okay, my work is done. And quite often that just doesn't work. And the reason it doesn't work, there's many reasons it doesn't work. One is people forget, another is you get a changeover of staff, you then have to redo the training and education. So that's one way of doing it. And that's person-oriented. You're relying on the person to make a change. Then you can bring in rules and policies. So that's creating guidelines. So again, guidelines are wonderful provided people read them. And that's one of the problems. People often, in our unit, I'm sure is just as guilty. We publish a guideline and we say our work is done, the guideline is out. Well, that's not always the case. Reminders and checklists. Checklists are great for things. However, checklists can also fade. People start to forget that they need to use the checklist. And then you get into design oriented. So automated, I'll go to automation and computerization. The example there would be order sets. So if you want everybody to do the same thing and you have an electronic patient record, what you can do, and with order entry, you can standardize things. You can say that we will do blood work on such and such days, and build intelligence into it. If their CBC shows a hemoglobin under this, then we do automatic CBCs. So you can computerize it that way. And then you can do forcing functions and constraints. And so forcing functions are the best way to go about making change. And by forcing functions require, in order for someone to get something done, it requires intention. So nothing's automatic. You have to actually have a discussion. You have to actually actively think about things. And so that would be the strongest. So what are the barriers to minimizing blood work in the NICU? Because there's for those of you who've worked, I don't think anyone here has worked with me necessarily, but if you do work with me, you will know that I tend to do a lot less blood work, at least I'm told, than other colleagues or some other colleagues. So what are barriers to minimizing blood work in the NICU? One is electronic ordering. So although I said electronic ordering can be quite useful, the problem with electronic order sets are if you forget that an order set is active that, let's say, says blood work should be done every 12 hours, that may go on for a few days before someone finally remembers, oh yes, we should cancel that specific order. Another problem is, although we all love our residents and we love teaching and we love our fellows, the reality is it's been demonstrated in the literature that the more junior the staff, the more blood work they do. So that's a barrier to change, is having your staff have the confidence to go without the blood work in those more stable patients. Another problem that we have is changeover of staff neonatologists. We're very good when we do handovers, at least in our center, about talking about the clinical issues that we're dealing with infants. We're not as good about reviewing critically all the blood tests that are done. Before I get flack from some of my colleagues that might be listening in, I'm sure some of you are very good at that, but I think at times we don't critically look at the blood work and see what can be minimized. And so should this actually be part of every handover? Should that be built into your patient handovers every day in the unit? A review of what's the upcoming blood work and asking the question, do we really need it? There's alternatives you can look at. And why should you look at alternatives? Dr. Anand, Dr. Ranger have published quite, well, and certainly Dr. Anand very recently, a review on the adverse experiences on brain development. Ranger looked at cortical thickness at 7 years in those born preterm and correlated painful procedures to reductions in cortical thickness. And so things we can do to try to avoid poking as much. On the right, you'll see transcutaneous bilirubinometry, which has been demonstrated to be quite effective and quite accurate compared to serum bilirubin, so that minimizes a poke. Another thing that you can do, and you can see on the bottom panel there, drawing a blood gas, many centers are able to get electrolytes right off of the blood gas. And yet you'll see quite often people are drawing electrolytes in conjunction with a blood gas. So one goes to the lab and one goes to the blood gas analyzer. I would say save the blood where at all possible. If you correlate maybe 1 or 2 serum electrolytes with a blood gas and find that on average the sodium is off by 3 and the potassium is off by, let's say 0.5, maybe you can just get away with using the 1 sample. And then the one on the left there is using microstream or side stream technology in order to sample carbon dioxide, as was done by Dr. Kugelman in Israel, looking at distal end-tidal CO2 monitoring as a replacement for frequent blood gases. So practicing what we preach, I wanted to show you that much like the first dogma, we created a forcing function. So back in October 2020, I released this memo. And what we did was we used to have the blood work for TPN automated. So what we would do is we would have blood work every day for the first 3 days, and then we would have it Mondays and Thursdays. And what we realized was that a number of things were happening. The first was whether it was a 24-weeker who had quite fluctuating electrolyte patterns, or it was a 31-weeker, we were treating them all the same, and that wasn't necessary. Some babies have very stable electrolytes, some babies have third spacing, they have other reasons that their electrolytes might become imbalanced. Why are we treating them all the same? The second thing that was happening was by having the routine blood work in place, there were actually babies who were no longer on TPN, who were getting poked for their TPN blood work because it was a standard order. So what we have done is we've created a forcing function, which is the highest level of safety in the hierarchy. And what we have done is we sent out this memo that if you want TPN blood work, you have to order it. So you have to tick off a box that you specifically want TPN on the days TPN blood work on the days you want it. And so that is just one example of something you can do to challenge some of the dogma that is in place. And routine TPN blood work is something we had in place for many years. And it really took someone noticing that we seem to be doing a lot of blood work that is not changing our management for this to change. So in conclusion, I hope I've shared with you that dogmas exist for many reasons. Some of these reasons are good because sometimes, sometimes a dogma is a dogma because it's actually right. It's something that we should be doing. But others can be quite outdated. As one of my colleagues taught me at one point, if you really want to change if you really want to think critically about your own practice, we need to resist the temptation to do what comes naturally, which is to read articles which support our current practice. And rather, we need to find the articles and read them critically, articles that are contrary to our practice. Because all too often, and I'm sure many of you will say, you may be nodding your heads right now when I tell you this, when you're building an argument or you're doing a presentation, and I may have even done it here, you tend to find papers that support your current belief. And when you have papers that don't support your current belief, you might gloss over them because you might not want to subconsciously change, but we have to force ourselves to challenge. And lastly, in challenging our own beliefs, I believe that we can have long-lasting positive impacts, not just for our own practice, but for the babies we care for. And with that, I'd like to thank you, and I'm open to questions.
Well, thank you, Michael. Thank you for a very enlightening talk. Arijit, you're saying something?
Yeah. So Thanks, Michael, for enchanting and enlightening talk to our change our daily practice and what we have believed over the years, but that may not be really true. So one of the questions is, will cyclical phototherapy be acceptable when we do face hemolytic anemias, like when bilirubins are really going strong or in that situations?
Yeah, that's a great question, and so thank you, Samandeep, for the question. It's very difficult to say specifically, for individual cases like this at this point, whether it should be continuous or cycled. Because again, we're talking about the only evidence we have right now for the cycled phototherapy that I can find is between 400 to 1,000 grams, and that typically wouldn't be the group that we would see the isoimmune hemolytic anemia in. What I would say though, and this is just honestly, this is a best guess, is I would start with continuous phototherapy in that case, because that would be our standard. And if you're getting a decent response, if the bilirubin is not going up and it's plateauing or even better coming down, and you wanted to do a trial of taking the baby out, allowing some breastfeeding, and then putting them back over and following up the bilirubin again. If you found it didn't really go up, then I think that would be a reasonable approach. But I certainly am not going to, and I was very careful in saying this, that, the only evidence we have is under 1,000 grams. So for the highest risk, I would still be careful. But again, I think it raises questions about whether or not, because again, there were high risk patients that were analyzed in that group and they found no difference whether it was 15 minutes or an hour. So I would say start for the highest risk with continuous, and then if you're getting a result, maybe look at allowing breastfeeding.
And in fact, there is one trial from India only, which had looked at intermittent phototherapy for babies more than 34 weeks. That was published in, I think, European Journal of Pediatrics from Srinivas Murthy's group. And
I think PGI, from PGI, right?
From PGI also,
yeah,
or somewhere. So, and they found out that like 12 hours off and 12 hours on, was as good as continuous phototherapy for babies more than 34 weeks. Of course, they were non-hemolytic varieties. And although I still do not understand, what benefit we'll get from 12 hours phototherapy and 12 hours.
Yeah, if you could send me that would be great, because I certainly couldn't find that one.
Sure.
But yeah, that would be great. Thank you.
Yeah, that's a great thing. So that's like monitoring the baby very tightly while avoiding an excess transfusion versus giving over phototherapy. So that would be a tightrope walking so far as hemolytic anemias are concerned, in cases of especially RH incompatibility and other things.
Yeah.
So the next question is, what is the strength of evidence to use the peripheral IV line for when you're using dextrose of more than 15%, so far as, because the standard of practice is like whenever you're going for more than 12.5%, go for a central line. Like that's one of the dogmas really. But one of the viewers want to know, what is the strength of evidence to use the peripheral line for higher dextrose infusions?
The strength of evidence is just what I presented. This is just something that, my goodness, I remember as a medical student coming through an exposure in the NICU. I mean, that was one of the first things I was told, and that was almost 25 years ago already. So that's just something that's been dogma for so long. And the theory was that the hyperosmolarity of the solution would lead to phlebitis and loss of the IV. But the one paper from 2010 that I've really found on this in a modern cohort has not demonstrated any loss. Now, again, as I mentioned before, there isn't a group in there that's 12.5%. So, Kieran, I mean, if they had included a 12.5% group, and let's say the mean longevity of the IV was 7 days instead of 4 days, you could say that there's a difference there. But I think if we're being honest, when I think about our babies that have hypoglycemia, I don't think I've seen hardly any babies that after 4 or 5 days still have the original IV. So that's with D10. So I think if they found no difference, if they found no difference at D15 or D20, with both having a mean of about 4 days. I think the evidence is fairly good that you don't need a UVC.
Okay, so that's like, so we can start actually using peripheral lines while infusing higher dextrose concentration really, and maybe so far as our experience is concerned, we need to work on it and see what's the difference. So evidence is really good. So the next question is, what is the usefulness of Billy blanket so far as phototherapy is concerned, while its usefulness to not to disrupt breastfeeding, as you told that like giving intermittent phototherapy
Right.
is okay so far as breastfeeding is concerned.
Yeah, and that's a wonderful point. You know, the Billy blankets certainly will allow breastfeeding and not interrupt breastfeeding. The comments I was making were more for the intensive phototherapy. So babies who are under lights in addition to the in addition to the Billy blanket. But for mild degrees of jaundice, the Billy blankets work wonderfully. I mean, as you all know, spectral irradiance, which is the measure of the intensity of phototherapy, is determined really by a couple of things. One is the intensity of the light source, and the second is the proximity to the skin. Ideally, you should be within 15 centimeters to get the best spectral irradiance in order to achieve the best effective phototherapy. So that I can't think of anything better than having the baby lay on the light source. So that's great, but there are many babies that need more than just the Billy blanket, and that's really what that dogma is about, is whether they need to stay under the lights.
Yeah, thanks, Michael. So one of the, like, it's a administrative question, like when you want to do these changes, change to a very old practice, very regular practice, want to change, and when you have got very senior people who have a strong belief and like mentors and all that, like professors and all that, so how do you really will do something to implement these changes in practice?
So yeah, I mean, I think that is that's always the question, is how do you deal with the strong-willed people, right?
Yeah.
I think that the best you can do is you present the evidence. You present the evidence, and I think that you present it honestly. You know, you present it honestly in the sense of present the articles that argue against your practice change. You know, don't just, because the problem is if you go in there and you say, if you go in there and you say, here are all the reasons why we should be changing, and you fail to acknowledge the reasons why you wouldn't change, people are not really listening to the talk. The other thing that I learned a long time ago and I try to put into practice is when I'm approaching a sensitive issue and I want to create change, I usually start my talk by putting it out there what the arguments against are likely to be. You know, and I'll say, okay, here are the problems that you're going to have with this up front. You know, here are the barriers we need to look at. Because if you acknowledge what the problems are going to be, it kind of disarms people. It makes them be more open. But I will say sometimes it doesn't work. Sometimes you need time. And the example I'll give you there, and you know, there may be one or two of my colleagues listening who were my mentors on this during this talk. Back in 1998 or 1999, I presented to our group as a resident pre-medication for intubation, and made what I felt were very compelling arguments for the obligatory use of rapid sequence induction for our elective intubations. And I can tell you, it went over like a lead balloon. Just people weren't ready for it. And so 10 years later, I came back as section head or division head, and I was in a position to really look at it. But also time had changed. You know, the statements had come out from the American Academy and the Canadian Pediatric Society endorsing it. So sometimes that's also it. It's about timing.
Michael, I have a question for you. So you considered normal saline for babies, you know, for the umbilical catheter. So we also had this kind of a dilemma at one point of time, especially very small babies. that how to give sodium to a baby on the first day itself. So we switched over to giving amino acids or through the umbilical artery. Have you ever considered an amino acid infusion through the umbilical artery rather than giving a sodium?
We have not. I mean, if we have through the UVC, we'll give what's called a starter TPN, and the starter TPN will have amino acids in it. But we've not gone through the umbilical artery with the amino acids. No.
So do you think of a potential problem with that kind of a strategy?
Offhand, no. I mean, even in our center, we will allow the use of infusions through the umbilical artery if that's all you have. We try to avoid it. And again, why do we try to avoid it? This probably, well, not probably, this predates me. I imagine at some point there was a complication. And so, it's the expression once bitten, twice shy. I think that, if you can give it through the UVC, we try to.
Yeah, because we've been using it for quite a long time, and I found one paper which was dated down to 1991, and after that nobody's actually even looked at this. So I talked to one more unit, and they're using it quite regularly, and that has actually reduced the number of the fluid that needs to be given, and especially the sodium in the first day. And my second, in continuation of your blood draws is, do you ever contemplate using placental blood for blood culture, microarray, or chromosome analysis or somewhere? Because for a small baby, that tends to be quite a lot of blood, especially if somebody says, a geneticist comes and says you need to draw 3 ml or 4 ml of a EDTA blood of a 600-gram baby. So what's your practice there?
Yeah, no, that's a wonderful question. We have at times drawn placental blood for a CBC in culture. We have done that. We have not done microarrays or genetic testing. Obviously for that to be done, you would need to in advance have a suspicion that you need to have a microarray.
Sure.
Typically, for our antenatal diagnoses here I can speak to Winnipeg or Manitoba. With our antenatal diagnoses, we tend to offer genetic testing prenatally. So there wouldn't be a need for the microarray at birth, but certainly if you work in a center where you don't have access to a lot of antenatal testing, then by all means, if you knew a baby had multiple anomalies and you want to draw the microarray, I don't see why you couldn't draw it off the placental blood. One thing that I would tell you, on some things, some testing, and I'm only aware of this because it's just come up with COVID, testing blood for looking for COVID in the blood, as far as antibody levels. There's something in the cord blood that I understand is interfering with the assay and giving inaccurate results here in Winnipeg, at least. So I think, I would be hesitant to very broadly say that cord blood can be used, but I think for certain things, CBC, it's been demonstrated you can use it, and certainly culture, I don't see why you couldn't use it.
Yeah, because in what we see in our practice, because many of small babies, like who are preterms and have been born out of premature rupture of membranes, they will end up starting antibiotics, even if they are mildly symptomatic, especially babies who are less than a kilo, where you do not have time. So in that scenario, placental blood is something which should be universal, and somehow it does not seem to get into practice.
Yeah. And as you say that, I can't help but think about, another dogma is, it's not so much a dogma, it's a practice that tends to happen is, how many babies with TTN are started on antibiotics?
Yeah.
When the evidence shows you that, if it looks like TTN on X-ray, I recall there being a study of something like 2,000 babies that all had radiographic TTN and 0 were positive, with blood cultures. Yet so often you'll see that it's just a reflex. It's what we do. We see distress and we say it could be sepsis, therefore we treat, even though I think we know it's not in many cases.
Yeah, I think we don't have any more questions. So,
But we have lot many compliments for sure. So people have been saying thank you, great talk, great like, and some of them are Spanish. So I'm sure that's like, so this is gracias means thank you. That I much I
Yes.
understand. I understand. And you know, so some people want to have an access to this talk. This is available on the YouTube. So for people to go and access that from the YouTube itself will be available from now onwards only. And I think if there are no more questions, we probably would like to thank you, Michael, for a very elaborate and interesting and of course intriguing talk. So hope other people would thinking about their practices, about what they need to do differently, from what they've been doing, and certainly come out with an out of box thinking for most of the things which I've been doing till now. Thank you, Michael.
Okay, thank you very much for having me.
So over to Manoj for the concluding remarks.
Well, we now come to the end of today's session. Let me also thank the legend of the day, Dr. Michael NARVEY, for sparing time to present an out-of-the-box series to all of us. Highly thought-provoking. Thank you, sir. I would like to also thank the moderators, Dr. Sanjay Wazir and Dr. Ajit Mohapatra, for moderating the session so well. And finally, all of you respected delegates who are joining us in this series, thank you so much. Let me also welcome you all to the next webinar in our series that will be on 14th of January. That is on caffeine for apnea of prematurity, evidence and beyond. The lecture will be delivered by the legend we all know, Professor Barbara Smith. So until then, goodbye.
Goodbye. Good night.
Bye. Good night. Thank you so much.
Thank you.